Welcome to this episode with Legends on Cardiothoracic Surgery. My name is Mia Lehtinen. I'm a resident in cardiothoracic surgery in Helsinki University Hospital, and I have the pleasure to be here with Dr. Marko Turina, who really doesn't need any introduction to the community of cardiothoracic surgeons, but we'll name just a couple of titles that you have. You're the founder of the one of the founders of the European Association of Cardiothoracic Surgery. You have been the president of the same association. You have been editor of the European Journal, and you also founded the Multimedia Library for Cardiothoracic Surgery. So many different titles.
Yeah.
So welcome.
Yeah. Pleasure to be here. Yeah.
Excellent. Of course, most of all, many of us really want to know how everything started. So we go back to the really early days of your career when you were still in medical school. Were there any hints that directed you towards surgery? And when did you realize that you really want to become a cardiothoracic surgeon?
I can tell you, I am the first MD in my family for 4 generations. They were intellectuals, but none of them ever went to medicine. My father was a lawyer, grandfather, great-grandfather, teaching. So for me, it was something, it's a really second choice. I wanted to go into engineering. And then I was watching our neighbors. They were studying engineers and they were spending nights drawing fine lines on the. I said, this is not exactly for me. And the second thing, which my father, he was slightly influential. He said, study medicine, it is the safe profession. Out of his own school class, half of them disappeared in the war. Who came back are doctors.
Of course. It's actually a funny thing. I was about to become an engineer as well, but then chose medicine for practically the same reasons. But I can imagine that engineering helped you a lot in the future, especially for research.
Yes.
You are originally from Croatia.
Croatia, from Zagreb.
Exactly. And you started your medical school there?
Medical school there, yes. It was a well-known medical school with a very strong Vienna tradition. Several of my professors were originally Viennese professors teaching, so anatomy was on an absolutely top level. I'm still now very good in anatomy.
Wonderful. Were there then special reasons that led you to move to Switzerland? Something with the political climate?
I was... as a non-communist, I was not actively opposed, but I couldn't stand the communism. It was sometimes I spoke maybe too loud or too much, and I had something which they called characteristic. At that time, I didn't know much about it, but the Communist Party, among my colleagues, they filled out a so-called characteristic. And with this characteristic, which I didn't know anything about, I would be absolutely blocked for getting better position.
Wow.
I didn't know about it, but to realize that my chances are bad there.
Yeah. Was there any particular reason why it became Switzerland of all the
I was, as a medical student, I had the opportunity to go in summer holidays, spend once in Edinburgh and once in Switzerland. And the director of the hospital where I was working in Switzerland made me immediately an offer I should come there after graduation. I took him up on that.
Okay. Well, good choice, probably, given how far you went in your career. There has been this definition that you've created yourself. You're nobody from nowhere. Could you elaborate a bit more on that definition?
Switzerland is, I don't know how well you know, Switzerland is a country where everybody knows everybody else. Small country, and especially so among doctors. They went to school together, they went to study together, they went to military together. In Switzerland, you have to go to military. So by the time you are graduated from medical school, you have a lot of friends, you know everybody on the first name basis. And I was like a sore thumb standing there.
And it was Zurich where you went to
No,
in
it
Switzerland,
was a
or?
small hospital in eastern Switzerland, Flaville. They regretfully they closed the hospital a couple of years ago, and it was so-called general hospital in the old system, about 110 beds, and we were doing mostly surgery, but also internal medicine and obstetrics, some gynecology. And I managed the birth of more than 100 Swiss babies in my time there, although primarily it was surgery. And this is the kind of a medical practice does not exist anymore. But so-called general hospitals, and they were everywhere in Europe, so-called general hospitals, they gave you a very excellent basic training in medicine.
Exactly. Were you were working in the same hospital for a long time, or did you
No,
then
I was for
move?
2 years at this hospital, and then I have seen something which moved me to go to cardiac surgery. I've seen that's your next question. I can tell you right now. My chief gave me a opportunity to go to Zurich, where was a color TV transmission of a heart operation. Professor Senning, at that time quite new in Zurich, was operating a ventricular septal defect, and it was transmitted by a special Swiss TV system which does not exist now. It was a three-channel color television in 1862. There was no color television. In 1962, there was no color television. They had a special system, and it was beautiful to see this operation and to hear Professor Senning's comment, answering questions, doing this precise surgery. And the synthesis of the excellent anatomical knowledge, the technical knowledge of the procedure, and the knowledge of the disease as such impressed me very much, because it's the synthesis of several areas coming in one person.
Exactly. Did you then create a strong mentor-mentee relationship with Dr.
See,
Senning? Was he a good mentor?
mentorship is maybe a wrong word. He was my mentor. I learned everything from him. He was a Nobel Prize candidate. A list of his first is huge. First pacemaker, first transpositional great arteries, first coronary endarterectomy. But he had a peculiar method. He would never assist an operation. I spent all my training there. He never assisted me a single operation. I was assisting him, and then one day he was doing all congenitals. On one Monday morning, there were two transpositions. On that, I never did a transposition myself. I assisted him. He decided he will not do congenitals anymore. I should do them. That was his method of training.
Okay.
It went okay, but it can be tough.
Yeah. So really, deep into really cold water. Well, are there any other ways how you would describe his way of training? Were there any special methods that he used besides this?
Well, let me tell you, it was first absolute intellectual brilliance. The people would be coming to our ward rounds and bring him a very strange X-ray. And he would just have a look at it. It said coccyomycosis, just like this, and came out of blue. He had obviously a photographic memory, but he had an intellectual brilliance. IQ, he was never measured. IQ must have been extremely high. He also studied 2 years of electrical engineering. That is how it helped him when he was building first pump oxygenator. Pump oxygenator was Crawford Senning. Crawford was the chief. Senning did the work. First pacemaker he built together with an engineer, with Mr. Elmquist. And for this pacemaker, it's some stories which nobody knows, is that first pacemaker, after they put in, worked for 2 hours. And they replaced it immediately, and the next one worked for 48 hours. Senning explained me later that it happened because they did most of the experiments in dogs, and obviously omic resistance of the dog myocardium is different from the human, so the battery is drained too early. So it just shows that slowly, but this is something you can learn from pioneers.
Definitely. You also trained in the US for a little while, wasn't that correct? In the USA for a little while, you went there for training as well.
Yes, yeah. And the United States, for me, remains the best, most systematically, it's the best training in surgery. If I have anybody now who asks the advice, I send him go to some time in US. I send my son, who is the doctor, I send him to US, and he did 3 years almost. He's now professor of colorectal surgery in my hospital. And so American training is the best. It's systematic. It knows the first year, second year, third year, know exactly what you are going to learn.
Exactly.
And you are continuously tested.
Did you then adapt the American model once you came back to Zurich and use it
I
for
tried
the Swiss?
to train my people in a systematic way. So it was, it's a European, it is less theoretical, less sessions. We had 2 times a week we had a teaching, but in America you spend the afternoons in teaching in the hospital. Maybe you have seen that. But I tried to teach by doing, so I would have the people working with me, and then I would stand on the other part and assist them in surgery, and until I slowly let them do on their own.
Exactly. And probably changed the field of Swiss training in cardiothoracic surgery in that way.
I could not influence the whole training in Switzerland, but I can tell you for a while, after I've been in Zurich 10 years, and many of my students left and went to be their own chiefs. For a while, all 6 major professorship and heads of cardiac surgery were my trainees, all of them.
If we continue to your research efforts, you already mentioned electrophysiology and Dr. Stenning's work there. How have surgical approaches to arrhythmias evolved since then?
It was first. I was doing a lot of experimental work on pacemaking. We were developing various types of pacemaking and electrodes in Zurich at that time, and I was doing most of this work in the lab. I'm not good in electrical engineering, but the problem arose when to implant a pacemaker. I mean, how long can you let a patient with a low pulse rate? And the cardiologist asked me if I could make a heart block. They would measure in an experimental animal all the hemodynamics. They would produce a heart block, and then they will measure it afterward to see the changes. And the only way at that time to produce a heart block was to open the chest, both with a cava, shortly cut his bundle, open the cava, and again. Well, it changes the whole hemodynamics. So I tried to do it without opening the chest, and went in there. Jugular vein identified with the tip of the catheter, identified his bundle, injected some chemical material there, total block, and then I should have followed on that. I did not. I didn't think there was a future in that. Nowadays, cardiologists are having a great future.
Exactly. Do you think there are any unique advantages that surgical interventions could provide to arrhythmia treatment?
There is, I think there is a big advantage of associated arrhythmia surgery. When you are doing, for instance, a valve replacement and doing electrical ablation of pulmonary veins, it's very good. Part of my career was with the WPW, and I had a lot of patients with the WPW syndrome. Nowadays, it can be reliably done by catheter. Except, and this is the only exception in which I did also in the later years, if there is an epicardial anomalous pathway. To get an anomalous epicardial pathway, you have to burn a lot of heart from the inside. Cardiologists do it from the inside. So these are the only patients I was doing a bundle ablation from the open chest.
another area where I know you have been working with the cardiologists
Yeah.
is myocardial infarction,
Yeah.
and especially PCI. Could you tell a bit more about
It
that?
just happened that Andreas Grünzig, who later went to fame and fortune, he was in the hospital as a young staff member, and he was doing dilation of the iliac artery and femoral arteries. And he asked me that he could do it in a coronary if I could produce coronary stenosis. And we went to the animal lab, and it is not easy to make a significant coronary stenosis because animals are extremely arrhythmia sensitive. But we found out how to do that, and I was producing, that was my modest effort, producing coronary stenosis, and Andreas Grünzig was a week later was putting in a balloon and blowing it up. So we found out he can blow up my 6-0 silk ligature. He cannot blow my 5-0 silk ligature. So these are small ways how the medicine progresses.
But completely essential and fundamental for the advancement of cardiology.
My real help to Grünzig was when he started clinical cases. That people don't know that in the beginning there were a lot of complications. Out of first 70 patients, 10% had a major complication. I mean, truly major. Being under resuscitation, we had to take them from the catheter lab under resuscitation in the operating room, 3 stories up. Once an elevator froze and we were in the resuscitation. Anyway, I'm very proud that we managed to salvage all these patients. None of them died, and out of 10, 9 had no signs of myocardial infarction. 1 had a minimal infarction. It just showed that a human body tolerates 60 to 80 minutes of ischemia with a full recovery.
Exactly. Wow. Another area, again, where you have done research in is artificial heart,
Yeah.
right?
I had a contact with with an Italian engineer who came to us in Zurich, said he has an artificial heart. And I looked at it, and it pumped, but that was the only thing. And he had a drive system which could be modified. He had a much too fast inlet. It would be traumatizing. It would be the valves would close with a bang, and there will be obviously major trauma. I worked with him for 2 years in modifying the system to get the physiological flow. And that was at the time when there was still some mortality in elective surgery. You know, there was you were patient close after myocardial infarction to do a coronary bypass grafting, and suddenly you couldn't get him off the pump, or double valve replaced with aortic and mitral, insufficient myocardial protection, and they wouldn't get off. And in these patients, we were putting in this pumping system, and it was very successful. It's of course, there were you get the patient decannulate, pump goes out, but there is a cerebral problem, or there is a sepsis. So things happen. I have one lady who went after bilateral mitral aortic valve replacement, was supported for 5 days, and I could take everything out of that. And she lived for about 10 years afterwards. I got regularly letters from her. So
Wow.
that is a success.
Definitely a success. It's pioneering. If we go then into innovations that you have done, how did you feel about this research work and your clinical work and combining the two? Was it easy to combine the two, and did they
I
complement
think
each other?
the most important thing is what I had. I had some additional training in cardiology, and I had some training in biochemistry. And I think it is essential in cardiac surgery, and it's something for you to think about. If you want to go into research, a work in an additional field, not purely surgery, but doing something like biochemistry today. It would be today I would go into immunology. That would be the thing. Then it teaches you exact language of science, and the language of science is something which has to be learned. The absolute rigid observation, methodically analyzing results, and this is something which surgery alone will not give you that. That is why I think if you plan a career in surgery for as a lifetime, additional training in something like immunology or something, a year or two would be a tremendous advantage for later career.
You have given all this background with research, really good clinical practice, going to the US, probably all this helped you to reach high leadership positions as well. And one of the leadership positions were that you were in the editorial board of the European Journal. Were there any
I
challenges
see.
in that?
I became editor when Hans Borst stepped back, and I thought it was something. I had that time full professorship. I had a well-running department, and I thought it would be something where I could devote some intellectual time because I was always admiring these two major American journals. And I realized we have nothing like this in Europe. A European journal was non-existent. That came ours. It was different. It was published quarterly. And then I decided to make something more out of that. And simultaneously, the electronic editing came, and I switched totally to electronic editing. And,
Oh. Um, was it difficult to combine? You were dean at the same time as you were editor.
yeah, it swallowed a lot of weekends.
Most
and,
definitely.
and I was never home before 9. It was, our dog was waiting at the door. When he the car coming, it immediately was awake and taking me the room. And the weekends hardly
Yeah.
any time. Yeah.
You had a huge impact as the dean of the medical school in Zurich. Was it challenging then for a surgeon to navigate through these academical challenges and all of the tasks that the dean has while being surgically active?
I think you have to reach a decision very early after graduating. Which way do you want to go? You want to be the best possible doctor helping the patient, or do you want to try to develop something new? And this is exactly, there are two ways. You can be the best possible surgeon and still you will not be an innovator or something, or you can become more of an intellectual surgeon. That is what appealed to me.
Absolutely. Did you make any changes in the university when you were the dean there? Something that affected the medical school?
Yeah, I could not change much at the university. Universities are rigid structures that I know very well. Ours is not so old. The University of Zurich dates from 1822, but it is nothing compared to German and British university, where this is no way to move. The one thing I introduced that I learned again from Americans is I introduced a periodic review of the medical school by two external visitors, absolutely top-level people. For instance, I had a Jean Braunwald for us as an external reviewer. It caused a lot of bad press for me, but it was very valuable because they have shown us the problems in the organization where we could improve, and that is my modest contribution to the university.
Modest, maybe fundamental as well. Something that also usually interests surgeons when they are looking at the careers of really legendary colleagues is what kind of people they have mentored during the years. And one of the mentees that you were a mentor for was Dr. Tomislav Mihaljevic.
Yeah.
what were the things that brought this mentor-mentee?
Tomislav Mihajlovic came to me without surgical training, very high recommendation, and he was in Vienna at that time, and basically in anatomy. And he had no previous surgical experience. At that time, there was something was wrong. We were extremely short of residents. And I had to put him as an intensive care unit resident after he was 4 weeks with us. And I was worried that I was coming in the evening, looking how it's, and I can tell you the nursing was absolutely smattering with Tomislav. He is such a person that they are one of very, very few who can do it from the very beginning. And it's a pity he had to leave Switzerland because Swiss, at that time, it was very difficult for a Yugoslav citizen at that time to get a work permit in Switzerland. And they were making difficulties for him to prolong his stay, and I advised him to go to Boston. He went to Harvard, and at that time, the chief of surgery there was a good friend of mine. They took him over, and he started that phenomenal. He was called in Boston. It was called Croatian sensation.
I can imagine that. Another way how you can judge that one person has really reached far in his career, on top of having mentees who become also famous, is who are the people you have met. And there are a couple of anecdotes regarding this, and I've heard one of the anecdotes is that you have actually met the Pope.
Yes, we had some kind of a private audience with Pope. There was a meeting, annual meeting of European Society of Cardiology, and the president of the meeting, chairman of the meeting, was the cardiologist of the Pope, and he arranged for several cardiologists. I was the only cardiac surgeon there for an audience with Pope, which is it's to see the Vatican from the inside. It's beyond belief. It's there's hundreds of years of history of richness.
Was there anything special that he was interested in? Perhaps the artificial heart, or
when you come in, it is a very formatized way. You are met by the Swiss guards, and then one guard goes with you with his colored pants, and the other goes behind us, and that is how we go. Long steps, polished marble. You come there to the rooms, everything polished marbles. The pictures on the wall are Renaissance or even earlier. It is, you are literally speechless when you see the Pope's personal say. And it was a funny thing is when he spoke just conventionally, and then we were ready to leave, and he said, he would like to tell us something. We could sit down, and he sat on the high chair, it is ex cathedra, and he said, I would like to tell you something about heart transplantation. I was the only cardiac surgeon there. I thought this is going to be bad, and now we have Pope about transplantation. And I was so surprised. He was fully supporting of the organ donation after brain death, and it said it's the way to do it. And you save many human lives with this, and so I was positively surprised with the Pope John Paul.
It must have been one really memorable encounter, definitely. Another anecdote, you are in good relationship with pilots because you're a pilot actually yourself. How did you get that hobby?
It was, for me, it was fascinating because it's similar to surgery. It's a synthesis of brain and hands, and I always thought that flying would be something as a second profession for me, but then I was more successful in surgery. But after I had it's expensive, but I managed to learn flying, and then we flew. My wife learned also, so we flew together sometimes in Switzerland. Switzerland is beautiful to fly on a nice summer day, to go over the Alps to Tessin and turn back over the Alps the other way around. It's fantastic. And I had at that time an opportunity to fly a fighter plane from the Second World War. I was, of course, with an instructor pilot, but to fly this P-51 Mustang, which dominated skies of Europe during the Second World War, it is incredible. The power of this machine is going through a narrow alpine valley and doing the rolls up there. It is fantastic. And the sky is the limit, as they say, for these planes.
Gives you a perspective, definitely. From the skies. You get the different perspective on everything.
Yeah.
Wow, this has been absolutely inspiring discussion. The life that you have lived, the career that you have taken, all the twists and turns, is definitely an inspiration to all of our generations following you and following closely and seeing what you come up with next, of course. Thank you very much for letting us interview you today and for taking the time for this interview.
It was a pleasure talking to you.
Thank
you.